ये लिख क्यों कौन 거기서 하트를 가시다가 하트를 가시다가
So everybody understood the concept of basic how the inguinal canal is formed or not?
Yes, sir.
Everybody understood that? No need of discussion over here? No need, just to revise in a short form first of all. So this is for example anterior wall over here. So inguinal canal is a normally musculo-aponeurotic tunnel. It's a tunnel. Okay. Okay. And then followed by the arch fibers. The arch fibers are made up of for example, if we divide it into anterior wall, first of all, this green color structure is nothing but the anterior wall over here, which is formed by the anterior wall of the inguinal canal is formed by external oblique aponeurosis. Is it alright? Could you understand? This fascia transversus will be through and through. It is not like two fascia transversals over here. Getting it or not? So external oblique, internal oblique, and transverse abdominis. So behind this will be the fascia transversus will be through and through. Getting it or not? And then followed by peritoneum will be through and through. Got it? So this part will be having a small opening over here. That is nothing but the superficial inguinal ring over here. Getting it or not? So this is the superficial most part, and then followed by a bit middle part will be formed by conjoint tendon. This so the anterior wall is also formed by internal oblique. Okay, muscular part of the internal oblique. Could you able to see that? Okay, this is the muscular part of the internal oblique deep to the external oblique aponeurosis. Could you able to understand why this thing is over here? Because the inguinal ligament will be giving rise to origin of two muscles. What are those? So the lateral half will be giving to internal oblique muscle, and lateral 1/3 will be given rise to transverse abdominis. Okay, so these muscles will be taking origin from the inguinal ligament also, not apart from the iliac crest over here. Iliac crest, and then followed by the half of the inguinal ligament will be giving rise to internal oblique, iliac crest, and 1/3 or 1/4 part of the inguinal ligament, later 1/4 will be given to transverse abdominis. So this part is also forming the anterior wall of the inguinal canal over here. Could you understand? Right? Right. So this internal oblique, which will be lying over here, for example, is also a part of anterior wall of the inguinal canal, which is directly in this manner, obliquely. Okay? How it is directed? Inguinal thing will be directed. So it is directed in this manner. Could you understand? So that's why the transverse abdominis will not be forming any anterior wall over here for the inguinal canal. Try to understand this. Okay. This is coming close to the inguinal canal over here in this manner. Could you understand? So the internal oblique is forming part of the or lateral half of the anterior wall over here, along with the external oblique aponeurosis. Could you understand? Right. Now the transverse abdominis over here. Okay. Right. So the anterior wall is formed by, as a whole, external oblique aponeurosis, and then followed by lateral half by means of internal oblique muscular fibers over here. Internal oblique muscle fibers over here. Okay. So this is the anterior wall over here. Then followed by these two muscles will be forming arch fibers, muscular fibers initially in this manner, and then followed by tendinous part over here. This is the tendinous part. Okay. So these are the arch fibers of the internal oblique and transverse abdominis in this manner. See here, could you able to understand? See here, initially these fibers are forming the anterior one, nothing but the internal oblique. Okay, and now whenever it is going towards the medial aspect, those will be forming posterior one. Could you able to understand everybody or not? Initially the same muscle fibers which are present over here are forming the anterior wall over here, but whenever it is reaching towards the medial aspect, it is forming the posterior wall over here. Could you able to understand? It will be in this manner. For example, the spermatic cord body is going in this manner, for example. Internal oblique and transverse abdominis will be going in this manner. Getting it or initially it is anterior, now it is posterior to the inguinal canal over here. Okay, this is the tunnel, inguinal canal. Getting it or so this is the conjoint canal over here, and these are the arched fibers of the inguinal canal over here. So you can see that the inguinal canal is passing deep to the arched fibers over here. Getting it or as if a train is passing through the arched tunnel over here. Getting it or So these arch fibers will be forming roof of the inguinal canal over here. Could you understand? Initially the anterior fibers, now it is forming the roof because it is moving over the inguinal canal. That's why it is forming the roof of the inguinal canal over here. Arch fibers. Getting it or and then followed by the conjoint tendon will be forming the posterior wall of the inguinal canal, where it is reaching the medial aspect. So anterior wall, roof, and posterior wall is formed by the internal oblique and transverse abdominis together. Getting it or apart from transverse abdominis over here. Getting it or right? So anterior wall, roof, and posterior wall over here. Okay. And then further deeper will be which structure will be present? Fascia transversalis. So this part is the fascia transversalis over here. Okay, one half if we take, this is the fascia transversalis, within which lies the deep ring over here. Getting it or so within the fascia transversalis is the deep ring. Okay. So entire fascia transversalis will be forming the entire posterior wall. Entire anterior wall is formed by external oblique aponeurosis over here. Entire posterior wall is formed by the fascia transversalis over here. Getting it or not? So in between the posterior wall and anterior wall which is present over here are the arch fibers of the internal oblique and transverse abdominis. Everybody understood this part or not? Right. So coming to the contents, what are the contents? What are the contents we have just seen?
In case of male, spermatic cord.
In case of male it is spermatic cord. So male it is spermatic cord entering into the scrotum. First testis will be over here. In case of female it will be round ligament of the uterus over here. Along with this nerve will be coming nothing but the ilio-inguinal nerve will be piercing the internal oblique muscle. Ilio-inguinal nerve and ilio-inguinal nerve and ilio-hypogastric nerves are passing in the plane between internal oblique and transverse abdominis, the innermost muscles. Okay, and then whenever it reaches over this region, this ilio-inguinal nerve will be piercing the internal oblique and will be entering into the inguinal canal in this manner. Getting it? So, ilio-inguinal nerve is not a complete content of the inguinal canal. From here to here is the inguinal canal. So, if anything is passing all the way from here to here or from here to here is a complete content. That is nothing but the spermatic cord or round ligament of uterus. Both will be forming the complete content of the inguinal canal. But this is a nerve which is coming all the way in this manner and will be piercing the internal oblique over here and pierces the internal oblique and enters into the inguinal canal only partly over here. Getting it out towards the medial aspect. So ilio-inguinal nerve is a partial content of the inguinal canal over here. This part is very much important. What is the complete content of the inguinal canal? What is the partial content of the inguinal canal over here? Understood or not? Right? But the iliohypogastric nerve will be passing all the way over here. Getting it on? Again, the iliohypogastric nerve also passes all the way from here and in between the external oblique aponeurosis and internal oblique aponeurosis and pierces the external oblique and supplies the skin over here. We'll be discussing that later during the lesson. Okay. So which nerves will be piercing? Internal oblique, ilioinguinal nerve and iliohypogastric nerves. Okay. Ilioinguinal nerve will be passing into the inguinal canal and reaches the scrotum over here or the labium majus over here. But the iliohypogastric nerve will be passing in between the internal oblique and external oblique and pierces the external oblique over here and supplies the skin at this level towards the lower aspect of the abdomen over here. Okay. We'll discuss the nerves later on. Okay. So this inguinal canal is obliquely situated in case of adults, but it is absolutely straight in case of children or child, whatever it is, children. Why it is so? Because the abdominal muscles of the children are not yet developed completely. Okay, so that's why this inguinal canal is absolutely straightforward in this manner. It will be straight in this manner in case of children, but it is oblique in case of adults. Getting it down? Right. So which? Okay, we'll discuss the hernias later on. Okay, so this is about the okay. First of all, what is deep ring and superficial ring? Okay. So this is the entry. Sorry, this is the entry point and this is the exit point over here because spermatic cord will be going all the way from here in this manner. Okay. Okay, that's before that. So roof and floor. Floor is formed. A floor of the canal is formed by inguinal ligament. So this part is the inguinal ligament which forms the floor over here. Could you see that? This is the floor. The medial half of the inguinal ligament will be forming the floor of the inguinal canal over here. Getting it on, right? So one more derivative of the inguinal ligament over here, that is nothing but lacunar ligament. See here, lacunar ligament will be attaching to. This is the inguinal ligament over here in this manner. So triangular shaped expansion of the inguinal ligament all the way from inguinal ligament towards the pectineal line, medial half of the pectineal line over here, towards the posterior aspect of the pubis. Okay, so that is the nothing but the lacunar ligament. What is that? Lacunar ligament, which is a derivative of the inguinal ligament over here. So this also, if it is present over here in this manner, this also acts as a floor for the inguinal canal over here. Get it right? So floor of the inguinal canal is formed by medial half of the inguinal ligament and also lacunar ligament as well. Get it right? So there are other derivatives of the inguinal ligament, nothing but pectineal ligament of Cooper, that's a different thing. But concerned with the inguinal canal, see here, this is a reflected part of the inguinal ligament over here. Reflected part. This is one reflected part. Here will be another reflected part over here. Getting it on? These both reflected parts will connect with each other to support the lower abdomen. Getting it on? Because this is a fibrous structure over here that will support the lower half, not lower half, lower aspect of the abdomen over here. Getting it on? So this is one reflected part and this is another reflected part. So if you see properly, this conjoint tendon, in front of the conjoint tendon is the reflected part of the inguinal ligament over here. That is forming the posterior wall of the inguinal canal. Could you understand? Could you understand, right? So inguinal canal will be going in this manner, right? Behind the medial end of the inguinal canal is the reflected part of the inguinal ligament over here, and behind that will be the conjoint tendon over here. This is the conjoint tendon. Could you understand or not? Right? So if you see, this part is forming the floor. This part and this part is forming the floor, but this part is going behind a little bit backwards over here. So it is forming the posterior wall of the inguinal canal over here. Could you understand it, right? So these are the walls and roof and floor, and of course different boundaries of the inguinal canal. Whatever you know already. Okay. Okay. Okay.
Hasselbeck triangle.
What?
Hasselbeck triangle.
Or Hasselbeck's triangle is okay, fine. Hasselbeck's triangle. This is the discussed the Hasselback's triangle. The base of the Hasselback, this triangle belongs to the peritoneum. Okay, not in the walls of the anterior abdominal wall. It belongs to the peritoneum. Getting it down? So it's the deepermost layer of the abdominal cavity. Okay, so this Hasselback's triangle has got an importance because this is the inferior. So let us see the boundaries first of all. The base of the triangle is formed by the inguinal ligament, and the lateral border of the rectus abdominis will be forming the medial boundary over here, and the inferior epigastric artery will be forming the lateral boundary of this triangle over here. So this is the Hasselback's triangle. You know the right? Hasselback's triangle. Okay, Hasselback's triangle. Okay, Hasselback's triangle over here. Okay, there's an importance for this. Lateral to this, inferior epigastric artery, there will be deep ring over here. Try to understand. Lateral to the inferior epigastric artery will be the deep ring. Okay. So here will be the deep ring over here. So if any hernia occurs, hernia means
abdomen
contents along with
with the wall of the abdomen.
Yeah, what is it exactly is needed?
Covering.
Absolutely. That itself says makes the hernia. Peritoneum, absolutely. Why? Because, for example, in case of development, if you take so initially there will be descent of the testis in case of embryological development. That means in the fetal life. The testis will be in the posterior abdominal wall in the fetal life. Okay, just before birth they will descend into the scrotum. Getting it on? Just before birth they will be descending into the scrotum. Before that the scrotum will be empty sac. Getting it on? Initially the testis will be in the abdominal cavity towards the posterior abdominal wall. Okay. So there is a fibrous bands which are connecting the testis with that of the scrotum in this manner, which is called the gubernaculum testis. Okay. So this is like a kite. For example, this is a kite over here. This is a thread over here. So if you pull the thread, the testis will be descending into the scrotum in this manner. Getting it out? Okay. So to make a way for this descent, initially the same gubernaculum testis will be dragging the peritoneum over here in this manner. Getting it out? So initially the same gubernaculum will be pulling off the peritoneum instead of the testis over here. Okay, instead of the testis, it will be pulling the peritoneum into the scrotum, so that a way will be made over here for the testis to come down. Getting it? For example, initially the peritoneum will be coming in this manner, and later on, through this way, the testis will be descended downwards. Getting it out? Right? Understanding or not? So initially, if you pull the peritoneum over here, there will be a space over here within the abdominal walls and the scrotum over here. Getting it out? So because the abdominal wall muscles will be in this manner, zigzag, right? So if you drag the peritoneum through the abdominal muscles into the scrotum over here, so there will be a way made over here. Later on, this peritoneum will be disappeared, but the testis will be descending through this way over here. Getting it out? Getting it out, right? So if any hernia occurs, because the peritoneum is situated over here, this must be disappeared in case of adults. Getting it out? This peritoneum will not be there in case of adults. Okay. This part of the peritoneum within the scrotum is called the processus vaginalis. What is it? Processus vaginalis. Okay. This will be disappeared later on. Okay. So this is a way maker which disappears later on. So after making the way, this testis will be pulled down over here through that same way. Okay. So if this persists over here, if it is not disappearing, so there is a chance of herniation of the intestinal contents to this sac into the scrotum over here. So always if there is a hernia, in case of inguinal hernia, the peritoneum is the must outside lining over here. Whatever it might be, the content over here, intestines or peritoneum, omentum or whatever it might be, the peritoneum must be the outer layer covering the herniated part over here. Getting it on? So if this omentum or intestines are entering into the scrotum, that must be covered by the peritoneum and then only it should enter. So hernia, in case of inguinal hernia, it is nothing but peritoneum along with the intestinal contents or abdominal contents, whatever it might be. Inguinal hernia particularly. Okay. This Hasselback's triangle. So we have seen Hasselback's triangle. Okay. This is the deep ring over here. Okay. Inferior epigastric artery will be entering all the way from extraperitoneal fat into the posterior aspect of the rectus abdominis. Okay. After passing deep to the this thing. What is this? Arcuate ligament. Is that not right? Arcuate.
Arcuate line.
Arcuate line. Not ligament. Arcuate line over here. Okay. So the deep ring will be lying lateral to the inferior epigastric artery, and the rest of the thing wall will be present over the medial aspect of the artery over here. The thing over here, what you are supposed to understand is the Hasselback's triangle. If you take this is the what is this part, right? Linea alba over here. Here will be the Hasselback's triangle. Could you understand? Here will be the Hasselback's triangle. Lateral to the Hasselback's triangle is the deep ring over here. Getting it on? So if any intestinal contents are herniating through this region over here into the scrotum over here, that is called the oblique inguinal hernia over here. Try to understand this. This is the inferior epigastric artery. For example, this is the lateral border of the rectus abdominis, and this is the inguinal ligament over here. So this is the Hasselback's triangle over here. Okay. With the herniation, for example, if the intestines are passing through this deep ring and passing through the inguinal canal and then entering into the scrotum over here, for example. So this is called the herniation over here. Okay, inguinal hernia. This inguinal hernia is called the oblique inguinal hernia or indirect inguinal hernia. Indirect inguinal hernia means there will not be any involvement of the wall structures of the inguinal canal. Try to understand this. Indirect or oblique means there will not be any wall structures. Whatever the walls which are forming the inguinal canal, those structures will not be involved whenever the herniation occurs over here. But whenever there is a direct inguinal hernia, the direct inguinal hernia will be occurring medial to this inferior epigastric artery or through the Hasselback's triangle over here. Getting it out? Laterally will be the indirect inguinal hernia. Medial to the inferior epigastric is the direct inguinal hernia. That means, for example, if a hernia is occurring through this part, in case of older people, there will be weakness of the abdominal wall muscles. Okay, that's why you can see the hernia in case of old age people generally, not in young age people. Okay, so if the same intestines passing through this Hasselback's triangle and entering into the scrotum over here, that is called the direct inguinal hernia. So whenever the intestines are moving through this part, which parts can be involved over here? Anterior abdominal wall muscles. Which muscles can be involved over here?
Fascia transversalis.
Fascia transversalis will be involved, and then conjoint tendon will be involved, and then external oblique. And then followed by this part. What is this part? Part of the inguinal ligament. All these things will be involved and will be entering into the scrotum over here. Getting it down? So, right all the way from posterior wall till the anterior wall, not anterior wall exactly, the posterior wall contents only will be entering into the scrotum over here. So, the wall structures are entering into the scrotum, that's why it is called the direct inguinal hernia. But the indirect, no wall structures are present over here. Is it not? There is no posterior wall or anterior wall, anything over here. Okay. So it is actually a canal or tunnel over here. So there is no obstruction over here. So straight away the intestines can easily enter. That is called the indirect inguinal hernia. Understood or not, everybody? Okay. This will be asked in the examination. Hasselback's triangle, either short notes or in the wider class. Okay. So this is about the Hasselback's triangle. This Hasselback's triangle is divided by means of an obliterated umbilical artery. Okay, there is a fold called, there is a peritoneal fold over here. Okay, because we are now in the peritoneal level. Because Hasselback's triangle belongs to peritoneum. The peritoneum, for example, if this is a peritoneum, for example, getting it down? So if you fold it into folds in this manner, peritoneum, if you fold it in this manner at certain areas, these are called the peritoneal folds. Getting it down? Okay, this is a peritoneum. If you make a fold in this manner, okay, on the posterior aspect. Okay, if this is the peritoneum on the anterior aspect, this is towards the abdominal cavity. If you make a pouch over here in this manner, that is called the peritoneal fold. There are three folds, we will be discussing that later. So among them, one fold will be having an obliterated means narrowed, completely narrowed, any vessel is called obliteration. Obliteration means narrowing, complete narrowing. Okay. So obliterated umbilical artery. Umbilical artery, you can understand where it is present, where you've got it embryological. Okay. Obliterated umbilical artery will be present at this part over here. Okay. So obviously there must be one more obliterated umbilical artery must be present over here. So how many veins and arteries in case of umbilical cord? Umbilical vessels, how many are there?
One artery, two veins.
One?
Artery, two veins.
No, that is one vein, two arteries. Okay, that's why two umbilical arteries over here, and of course vein is not there over here, but two umbilical arteries, obliterated umbilical arteries. Okay, so this obliterated umbilical artery divides the Hasselback's triangle into two halves. One is the medial half, one is the lateral half over here. Okay, what are those? This medial one is called in area. Supravesical region, because it is just above the urinary bladder over here. Supravesical. Okay, and then this one is what? Supravesical fossa. Sorry, fossa. Supravesical fossa, and then so if you consider this entire inguinal region, okay, if you this fossa and this fossa, two fossae in case of entire inguinal region, for example, because the right iliac fossa and left iliac fossa are termed as inguinal regions. Okay, if you have two depressions over here, those are called the fossae. Okay, so this fossa towards the medial most aspect is called the supravesical fossa. Vesicle represents the urinary bladder. So urinary bladder you can expect over here, is it or not? So supravesical fossa over here, and rest of the thing is the inguinal fossa. This entirely is the inguinal fossa, apart from the supravesical fossa over here. Okay, so you can understand this is the inguinal ligament over here. So this one is called see here, this part is called the medial inguinal fossa. This entire part is called the lateral inguinal fossa. Understood or not? Right iliac fossa, left iliac fossa. Based on this, you can understand it is like a depression over here. Among them, there are three depressions. They have differentiated based on the Hasselback's triangle and the other things over here. Okay, what are those? Hasselback's triangle is divided by means of this obliterated umbilical artery into two halves over here, two fossae over here. So one is just above the urinary bladder, that is called the supravesical fossa over here, and one is lateral to it within the same triangle. This part of the triangle is called medial inguinal fossa. Okay, and apart from this triangle, this entire fossa is termed as the lateral inguinal fossa. So lateral inguinal fossa is the biggest one, and then medial inguinal fossa. Don't think that this is as the medial inguinal fossa and this is as the lateral inguinal fossa. Don't confuse. Always put the supravesical fossa first, then divide the entire inguinal fossa into two parts. One is the medial inguinal fossa and one is the lateral inguinal fossa over here. Understood how to do it, right? So, if any hernia occurs over here through this part, either this triangle or this triangle, that is termed as which hernia? Direct or indirect? Direct inguinal hernia. Apart from, other than this triangle, whenever the herniation occurs through the deep ring over here, that is called the indirect inguinal hernia or oblique inguinal hernia. Okay, that is the basic difference you are supposed to understand. Okay. So let us see how the herniation occurs. Okay. What are the things which are covering the hernia? Have you read or not? Have you read or not? What are the coverings of the hernia? It should be short notes, like 4 marks or 6 marks or whatever it might be. Okay. Let us see that first of all. We have one more D for the inguinal canal. We'll discuss on which day tomorrow. Why Monday? Why not tomorrow? Holiday, absolutely.
And day after tomorrow will be
tomorrow. Day after tomorrow.
Awesome.
Obviously, many people will be. It's okay. And then Saturday. Saturday no class, and then Monday we can that easily. Okay. So let us see that first of all. This is the fascia transversalis. Okay. Now we are going to see how the herniation occurs. That means the walls of the hernia. Okay. This part is very much important. Okay. First of all, let us see that this is the fascia transversalis over here, and this is the deep ring over here. This deep ring is not actually the ring over here. It's the depression through which the spermatocord enters over here. Getting it out? Right? So spermatocord will be pushed in this manner, or you can in this manner also you can see, in the reverse manner also. From the testis, the spermatocord will be entering into the urethra, or during the descent, the spermatocord will be pushed down or pulled downwards over here. Or any ways you can see that. Okay. So this is the fascia transversalis over here, and this is the deep ring over here. This deep ring is lined by a fascia that is called. This deep ring is lined by a fascia that is called internal spermatic fascia. Internal spermatic fascia. That means at the level of the opening of the deep ring, there is a fascia called the internal spermatic fascia. Getting it? Let us see what are other things over here. So within the canal over here, within the canal, there is one more fascia called the cremasteric fascia over here. Okay. Over here there will be cremasteric muscle. We'll be discussing that later. There will be a fascia called the cremasteric fascia. Okay. So within the inguinal canal, this is the deep ring, this is the superficial ring, for example. Within the canal, there is a fascia called the cremasteric fascia. Okay. For example, within the canal, there is a fascia obstructing it. That is nothing but the cremasteric fascia. Okay. Cremasteric muscle will be arising over here. We'll discuss that later. Okay. Then at the level of the superficial inguinal ring, there will be one more fascia called the external spermatic fascia. Okay. By this you can understand everywhere the openings are covered by a fascia. Isn't it not? Right? So deep ring is covered by a fascia called the internal spermatic fascia. The content is same, collagen fibers and now all other things. Okay. And the spermatic fascia within the inguinal canal, that is also a fascia which is nothing but the cremasteric fascia over here. And at the level of the external opening, nothing but superficial inguinal ring, there is one more fascia called the external spermatic fascia. Okay. So whenever the herniation occurring over here, through this, for example, this is the herniation occurring through this. Okay. Let us see that. What might be this hernia? It is termed as oblique or direct inguinal hernia. Okay. Sorry. Indirect inguinal hernia. Indirect inguinal hernia. Okay. Indirect inguinal hernia or oblique inguinal hernia. Okay. Then what are the things which are lying? For example, this is the intestine, for example. Whenever it is passing through this canal, so which layers will be carried along with it? For example, within a railway track, if you keep anything, obstructing the train, that will be pulled away by the train. Is it not? Right? If you keep a bicycle, the bicycle will be carried along with it. If you keep a lorry, that will be carried along with it. In the same manner, imagine the intestines as the drain over here. What are the obstructions over here are the fascia, different fascia over here. Got it? So when the train is passing over here, the first of all, which layer will be carried through the deep ring? This part will be.
the peritoneum.
No. Before that?
The peritoneum.
Always the intestines. Here will be the peritoneum. Is it not due to the peritoneum? For example, if you imagine the abdominal cavity as a fridge, for example. Fridge. Okay. Or microwave oven you can take. Outside there will be different color. Inside only white color will be there. Is it or not? So imagine the white color as the peritoneum and the outer layer is the abdominal cavity. Could you understand now? Right? So whatever the things, shelves which are present, that comes under the peritoneum with different folds of the peritoneum. But the outer abdominal wall, skin, muscles and everything will be forming the outer color over here. Getting it on in a fridge. So first of all, the contents within the fridge, if you have to take any apple or anything from the fridge, you have to open the fridge and then you have to take it out. Right? The same manner, this is the door of the fridge, for example, which is formed by the peritoneum over here. Getting it on? And then followed by extraperitoneal fat or extraperitoneal tissue over here. Okay. So whenever the intestines are passing through the deep ring over here, first of all it should carry this part nothing but the peritoneum, and then followed by extraperitoneal tissue or fat. Okay, tissue. Okay, so this part is the abdominal cavity. which contains the intestines and all the other viscera. Okay, generally the intestines will be herniated over here. Okay, so whenever it is passing, it should cross. First of all, it should carry the peritoneum over here, parietal peritoneum over here, then followed by the extra peritoneal tissue, then followed by whenever it is entering, it will be carrying which fascia? Internal spermatic fascia. So first of all the way from here, peritoneum is the first one, and then followed by the extra peritoneal tissue is the second layer, then followed by the internal spermatic fascia is the third layer, and then whenever it is passing through the canal, it will be carrying a fascia called the cremasteric fascia over here, one more obstacle over here. Okay, so this is the fourth wall, and then followed by over here external spermatic fascia, which is the fifth covering of the actual intestine over here. Could you understand? What are the layers which are carried along with the intestines over here whenever it is getting herniated? Getting it or not, right? So all the way from, so these are the layers of the hernia carried along with the intestines over here. Getting it or not? So this is the indirect inguinal hernia or oblique inguinal hernia. Okay. So whenever the intestines are carried through the deep ring towards the superficial ring over here, there is no obstruction because the arch fibers are present over here, posterior wall is present over here, anterior wall is present over here. There is no obstruction for these intestines apart from these fascia. Got it all?
So how is the cremasteric fascia present?
Just like a fascia. For example, this is the superficial inguinal ring. There will be a fascia, small fascia over here. The small fascia will be covering in this manner. Fascia is nothing but the loose areolar connective tissues of the small fascia. So if the intestine is passing through this, obviously the fascia will be carried around it. The fibers, the collagen fibers will be passing along with it. That's all, nothing but the fascia. Got it or not? So these are the things which are lining the what is this? Intestines in the hernia. Okay. Along with it, whenever it is entering into the scrotum, it will be covered by the skin and a muscle called the dartos muscle. Okay. So whenever these contents are entering into the scrotum contains a muscle called dartos muscle. You'll be getting the foldings of the scrotum because of this muscle, dartos muscle. Okay, you'll be discussing during genitalia. Okay, there is a muscle called dartos muscle. And then followed by the skin of the scrotum. So these are the linings of the indirect inguinal hernia. Getting it out? So what are the things which are lining all the way from above downwards? Peritoneum, parietal peritoneum, then followed by extraperitoneal tissue, then followed by internal spermatic fascia, then followed by cremasteric fascia, then followed by external spermatic fascia, then followed by dartos muscle within the scrotum, and then followed by the skin of the scrotum. So this is the actual hernia in case of indirect inguinal hernia. Getting it out? So if you open the scrotum, you will get all these layers. You can't see, but you can separate the layers, all these layers over here. Nothing but the fascia over here. Got it out? That is in the direct inguinal hernia. So what is direct inguinal hernia? Direct inguinal hernia will be passing through a triangle called Hasselbalch's triangle. Okay. So imagine that this is the lateral border of the rectus abdominis over here. This is the inferior epigastric. Could you able to remember? Hasselbalch's triangle. So this is the lateral border of the rectus abdominis over here. This is the lateral border of the rectus abdominis over here. Okay, six packs and everything. This is inferior epigastric artery. This is obliterated umbilical artery. Okay, in case of adults, the umbilical arteries are not needed. Is it not? Right. So obliterated umbilical artery. So lateral to that is the deep ring over here. So obviously this is the indirect inguinal hernia or oblique hernia over here. So if you get the inferior epigastric artery, whenever you open the abdomen, if you get the inferior epigastric artery, if the herniation, the swelling occurs all the way towards the lateral aspect, that comes under indirect inguinal hernia. But if it is occurring through this triangle or medial to the inferior epigastric artery, that indicates it as the direct inguinal hernia. For example, For example, a patient has come with the complaints of swelling and pain in the scrotum. Scrotum and groin region. You know the groin region, where the groin region is. Just above the scrotum is the groin region. Okay? Right. So, patient is complaining of swelling in the scrotum and pain in the groin region over here. Getting it? So, as a doctor, you can easily identify there is a enlarged swelling over here on the scrotum, which is not normally present over here. So, you can reduce, any hernia can be reduced apart from few other hernia, I will tell you later. So, you can push the herniated mass back into the actual position because of the weakness of the abdominal muscles or because of the weakness in the, not weakness, because of any other reason, increase intra-abdominal pressure, there will be herniation of the intestinal contents into the scrotum. Okay, the direct hernia occurs because of the weakness of the abdominal wall muscles, and the indirect hernia occurs because of the increased intra-abdominal pressure that will be pushing the intestines through this ring into the scrotum over here. Yeah. Then how to differentiate clinically when a patient comes with the swelling and pain over here? So you can reduce easily this part over here. You can reduce the swelling through this part. So the intestines will be entering back into the abdomen. Then how to differentiate what is this? Direct inguinal hernia or indirect inguinal hernia? How you can differentiate? Try to imagine. For example, very easy. For example, if you know where the deep ring is situated, then you can easily identify. Where the deep ring is situated, for example, this is the inguinal ligament over here.
2.5 centimeters.
Yeah, exactly. What is that like?
So 2.5 above 2.5 centimeters above the mid-inguinal line.
Mid-inguinal point. Mid-inguinal point. Okay. So let us see that this is the anterior superior iliac spine, and this is the pubic tubercle over here. This is the inguinal ligament over here. Above the 2.5 centimeters above the mid-inguinal point. Okay. About 2.5 centimeters. This is over here. So if you press your finger over here after reduction, and if you ask the patient to cough means because cough leads to increased intra-abdominal pressure, again the intestinal contents will enter into the scrotum. Getting it out? If you cough, obviously the abdominal will be contracted, so intra-abdominal pressure will increase. So that will push the contents through the ring or into the abdominal, the anter-abdominal wall into the scrotum again. Okay. So if you close the deep ring over here, and if you ask the patient to cough, again the intra-abdominal pressure is increased, and you can't see any scrotal swelling over here, so that indicates indirect inguinal hernia. If you close this and again the herniation is occurring over here, that indicates direct inguinal hernia. Could you able to understand now? Right? Then what is this mid-inguinal point and midpoint of the inguinal ligament? There are two things which should be asked in the examination. Okay. One is what's the time? 3:30. So one is the mid-inguinal point and one is midpoint of the inguinal ligament. Okay, both these things are very much important. Okay, to identify the femoral artery and to identify this deep ring over here. Okay, what are the differences over here? Okay, first of all, see that mid-inguinal point. Inguinal is referring to inguinal region over here. Where the inguinal region is extending, it will be extending in between anterior superior iliac spine and pubic symphysis over here. Getting it out? Pubic symphysis is the other end point for the inguinal region. Is it not? This is one inguinal region, this is another inguinal region. Okay. Mid-inguinal point. It is the midpoint of the inguinal region over here. Okay. So if you take till this part, not exactly this part, if you take these 2 points, that means the anterior superior iliac spine and the pubic symphysis, if you take exactly half of this over here, this point will be the mid-inguinal point. Or you can keep it over here also. Anywhere over here. Okay. Mid-inguinal point over here. And midpoint of the inguinal ligament, see here, it is about the inguinal ligament, not the inguinal region. So you can easily say that it is in between the pubic tubercle and anterior superior iliac spine. That is the extent of the inguinal ligament over here. Anterior superior iliac spine and the pubic tubercle. So these both are the ends for the inguinal ligament over here. If you keep a midpoint over here, that will be the midpoint of the inguinal ligament over here. Understood or not? Mid-inguinal point is with respect to the inguinal region, and midpoint of the inguinal ligament is specifically for the inguinal ligament. Don't confuse, it will be definitely asked in the examination. Okay? Right. So now we have been discussing about the deep ring, about the mid-inguinal point over here. Okay? So midpoint of the inguinal region over here. Okay? About 2.5 centimeters above the inguinal ligament. If you press it over here, if the herniation is not occurring after coughing, it is nothing but the if you close the deep ring and the herniation is not occurring after coughing, indirect inguinal hernia. But even after coughing, whenever you after closing, even if the hernia is occurring, that is direct inguinal hernia, because the herniation is occurring through this part. No chance of indirect inguinal hernia over here, through the deep ring over here. Understood? Right?
That is 2.5 centimeter above the
Mid-inguinal point. Mid-inguinal point. Entire inguinal region above that. Okay? So that is the difference. Clinically you have to identify. Okay? So in case of surgical thing, in case of surgery, you can't identify, you will be opening layer by layer. Surgically, you will be opening layer by layer. So whenever you get the inferior epigastric artery over here, so whenever the intestinal contents are passing medial to the artery, in case of surgery, that indicates
the
direct inguinal hernia. So this acts as a guide to identify the herniation where it is occurring over here. Could you understand? In case of surgery, if you identify the inferior epigastric artery, if the herniation is occurring lateral to the inferior epigastric artery, that indicates indirect inguinal hernia. If it is occurring medial to the inferior epigastric artery, that indicates direct inguinal hernia. This is surgical, that is clinical. Understood? Right? So inferior epigastric artery acts as a guide to identify the neck of the herniated part over here, because herniation can be seen through this part and through this part also. To identify the neck, for example, if you fill the balloon with the water, the uppermost part will be narrowed and lowermost part will be wider. So this you can say it as a neck, isn't it? So in the same manner, imagine that the herniated portion is the balloon over here. This part will be the neck and this part will be the neck over here, isn't it? The narrowed portion will be the neck of the hernia. Could you understand? So to identify the neck of the herniation over here, so this part is the narrowed part in case of indirect inguinal hernia, and this part is the neck in case of direct inguinal hernia over here. Could you understand? Right? So, in case of Hasselbalch's triangle, through these two triangles, the herniation will occur. Direct inguinal hernia. Okay. Then what are the coverings which occur through this part over here? So, if it is occurring through this triangle over here, that means which part is this? Which fossa? Medial inguinal fossa. So, if the herniation is occurring through this part, so what might be the coverings of this hernia over here, all the way from back to front?
So what's the peritoneum?
First of all,
peritoneum
and then followed by extraperitoneal fat, and then followed by fascia transversalis, and then followed by that is the difference.
There will be the
And
muscle.
then followed, what is it?
The muscles will be there.
Exactly. What is that? What are the muscles?
The transverse abdominis muscle first, and then
Okay.
the internal
Okay.
abdomen.
But those will be arching in this manner, is it not?
Yes, sir.
Arching in this manner over here. Okay. So what structure will be coming over here? Conjoint tendon. So the conjoint tendon will be carried along with this. Getting it down? Conjoint tendon will be carried along with this over here. And then, do you think that reflected part of the inguinal ligament is present over here? No, because reflected part is present over here. It was the medial aspect. Okay. So conjoint tendon, then followed by. So you can see that peritoneum, extraperitoneal tissue, fascia transversalis, then conjoint tendon will be over here, and then entering into the inguinal canal over here, carrying a fascia called the cremasteric fascia, and then followed with external spermatic fascia, and then followed with dartos muscle, and then followed by
Skin of the scrotum.
Skin of the scrotum, absolutely. So what is missing over here? Internal spermatic fascia is missing because it is not entering through the deep ring over here. Getting it out? Instead of internal spermatic fascia, you can use the conjoint tendon. Rest of the things are same. Got it or not? Understood or not? Right? So if you take this triangle, what might be the layers of the hernia which is present over here? All the way from here again. Peritoneum, extraperitoneal tissue, then followed by fascia transversalis, then followed by
The
conjoint tendon along with the reflected part of the inguinal ligament, and then followed by cremasteric fascia over here. But here it is external spermatic fascia, and then followed by dartos muscle, and then followed by the skin of the scrotum. Understood how it is varying over here? Understood or not very well, right? So these layers of the hernia, inguinal hernia, are very much important for the examination purpose. Okay, they will be asking what are the layers which are covering the indirect inguinal hernia, what are the layers which are covering the direct inguinal hernia which is passing through supravesical fossa. So you have to write, instead of cremasteric fascia, you have to write conjoint tendon and reflected part of the inguinal ligament over here. Understood or not, everybody? Right? Rest of this external spermatic fascia and darkest marginal skin are constant for all these things, all these hernias. But this level will be varied over here. Getting it or not, everybody? Understood or not? Right? So okay, you people know all the origins and insertions of all these external oblique, internal oblique and transverse elements are not right?
Yes, sir.
No sir, tell me. We'll be discussing in the next class, no? Because we have time, enough time in the next class also. If you know, you can tell me. External oblique, what is the origin and insertion? Lower 8 ribs, outer surface. And then insertion will be?
The linea alba.
Linea alba.
The insertion is iliac crest also.
Okay,
Iliac crest also. And then one third part of the inguinal ligament.
Two-thirds.
No.
What is it?
No.
No chance at all. What? No. Internal oblique and transverse limb. It's not external oblique. No? Not external. Internal oblique and transverse limb. 2/3 part and 1/3 part. Absolutely. Right. Aponeurotic part will be there, and that will be converting into inguinal ligament. So over the inguinal ligament, obviously the logical.
It's not insertion.
Absolutely. Continuous. Absolutely. It's okay. What are the hernias, incisional hernias and everything? Just now somebody asked me what is that communication between what is that somatic and radial pain. Referred pain. Who is that?
Referred.
Okay, cool. Referred pain, no? So what is the referred pain? So if you are getting pain in one area, for example, I will go all the way from superior extremity towards the abdomen, for example. First of all, there is a intercostal brachial nerve. Is it not connecting which parts? What's the time here? What's the time? So intercostal brachial nerve is nothing but the lateral cutaneous branch of intercostal. For example, intercostal brachial nerve is a branch of nothing but the lateral cutaneous branch of the second intercostal nerve. Is it not? So this will be going and joining with the
medial cutaneous nerve of arm.
Okay. So the referred pain means, for example, this is the thoracic wall. Is it not? So this part is the thorax and this part is the arm part. Is it not? Right? Because all the ribs and intercostal nerves are present within the thoracic cavity, and this medial cutaneous nerve is present in the arm. Right? So if you get an abscess over here, for example, there is an abscess. What is an abscess? Accumulation of pus. Abscess means pus. Okay. Accumulation of fluid is called vessel. Okay. Abscess means pus. Okay. So within a closed cavity, there is accumulating pus because of the fighting between antigens and antibodies. That is nothing but the abscess over here. Okay. So if there is an abscess which is present over here, obviously there will be fighting going on that leads to inflammation. Inflammation, what are the things? Rubor, pallor, dolor, calor. Rubor, pallor, calor, dolor. Okay. Right. Dolor only, no? I forgot the physiology. Rubor, redness, pallor, edema, and then what is my piece? Okay. Okay, inflammation, what are the things? The pain will be there for the inflammation. Okay, I forgot the physiology. It's okay. So abscess, there must be the pain, is it not? So if the pain is occurring over here, so this sensation will be carried by means of this intercostal nerve. Is it not? intercostal, this is a sensation that will be carried through the intercostal nerve towards the spinal cord, and that will be felt by the brain. Okay. So the same pain is traveling through this nerve and it is getting pain over the arm also. That is called the referred pain. That means a pain over here which is carried through this nerve and the pain will be felt over the arm also, even there is no pathology over here. That is called the referred pain. So pain, the source of pain is over here, but it is paining in some other place. That is called the referred pain. Understood or not? So in case of pain with the viscera and pain with the skin over here. Okay, we'll see that. For example, there is a kidney, for example. Okay. Kidneys pain will be carried by what are the segments yesterday we have discussed? What is it? No? Okay. T11, T12, L1, and sometimes L2 also will be included. Okay, L2 take L2 also. Okay. So all these sympathetic nerves over here will be carrying the pain all the way from kidney towards the spinal cord and brain. You know? So these are the nerves, nothing but the sympathetic nerves which are supplying the kidney will be carrying the pain towards the spinal cord and finally towards the brain over here. You know? Right? So this is the sympathetic nerves. Okay, sympathetic nerves will be giving rise to some function, whatever it might be. Okay, the pain will be carried through this sympathetic nervous system. Sympathetic nerves over here. Okay, so now we are seeing the viscera with the spinal cord and the brain over here. There is no chance of skin over here. Okay, so this sympathetic nervous system belongs to autonomic nervous system, nothing but the sympathetic and parasympathetic nervous system. So sympathetic nerves will be carrying the pain from the kidney towards the brain over here, or spinal cord, whatever it might be. Okay, but if there is a communication between the somatic nerve, for example, this is the skin of the abdomen over here. This is the posterior abdominal, this is the anterior abdominal, for example. So this is the skin which is having the below the umbilicus part. This umbilicus part below that will be T11, T12, and L1. Okay, getting it up. So if this intercostal nerve or somatic nerve, for example, T11, T12, intercostal nerves obviously and subcostal nerve also. So whenever it is supplying the skin, it will become somatic. And of course it will be supplying the voluntary muscles also. Somatic nervous system will be supplying the voluntary muscles and skin for this cutaneous sensation. Okay. So whenever these two are communicating with each other, sympathetic nervous system is communicating with somatic nervous system over here. Okay, somatic nervous system over here. Okay. So whenever the pain is common for the kidney and the pain is common for sympathetic nervous system and somatic nervous system also. Getting it? The same pain will be carried through this part and also through this part also. Getting it? Through this part it is a sensation carried by the sympathetic nerves, but here the sensation is carried as a referred pain over here. Getting it? Because there is no spinal cord or brain over here to do some activity over here. Getting it? So it is acting as a referred pain for the abdomen over here. So whenever there is a pathology in the kidney, that pain is radiated all the way in this manner like an arc over here towards the anterior abdominal wall. So if a patient is complaining of pain in this part is called the loin over here, and whenever it is radiating towards the groin, that indicates some pathology in either kidneys or in ureters. You can come under some diagnosis, provisional diagnosis you can come. Okay. So in this manner, if there is a communication between the sympathetic nerves and somatic nerves, this pain will be referred over here towards the abdomen through the somatic nerves, nothing but the intercostal nerves over here. You know. So that's why this area is termed as a dermatome, because it is radiating towards the skin, not to any other abdominal organ over here. You know. So this pain, kidney pain, is felt over the anterior abdominal skin surface over here, not in any other viscera. Kidney is not radiating to the intestines, or kidney is not radiating to the stomach over here. Kidney is radiating to the skin over here. Get it now? So this will be carrying the pain sensation. Okay, pain sensation. So for example, if the patient is lying with a pillow over the back over here, for example, so the pain will be aggravated. So that sensation will be carried to the brain. So what will the patient will do? He will be changing the direction of lying posture. Could you understand? So if he sleeps on prone position, the pain will be reduced. So that is the activity which is produced by the motor activity of the spinal cord or brain, whatever it might be. So that will be done through sympathetic nervous system, but this pain will be constantly radiated to the skin over here through the somatic nervous system, that is the referred pain over here. Understood or not? Right? Understood or clear? Okay. So this is the communication between the sympathetic nervous system and somatic nervous system. The same thing applies to the cardiac pain and stomach pain also, whatever it might be. Okay? That's all. We'll see the next rest of things tomorrow. Day after tomorrow. Oh, I forgot the
Attendance.
paper.